Okay, today in the digestive system, in this video, we will study about the stomach. Okay, so in the physiology of the stomach, we have to see first the secretions of the stomach and the movements of the stomach and the digestive activities that takes place in the stomach and the regulations of all of them. As always, the regulation is very important. Okay, so let's first study a little bit about different parts of the stomach. Okay, and then see what are the different things that is being secreted, including the hormones and the secretions. Okay, so the esophagus, that is what we have studied in our previous class. Okay, here you have the lower esophageal sphincter. Okay, and the food moves from the esophagus to the stomach, passing through the lower esophageal sphincter. Okay, once it comes to the stomach, okay, the initial movement of the food is towards the region called as fundus. Okay, so in the fundus, the major role of the fundus is to store the food. Okay, store the food. So as soon as the food is coming, it is stored in the fundus. Okay, so by a process called as receptive relaxation. So the receptive relaxation happen and the food goes over here. Okay, so then once the food stops coming from the esophagus and the lower esophageal sphincter is closed for almost like remain closed for almost like 10 to 15 minutes, then the fundus contracts and push the food towards the body. Okay, in the body you have the parietal cells, okay, which cells secretes the hydrochloric acid and the HCl, and then the intrinsic factor. Okay, and also there are chief cells that secretes the pepsinogen. So you can see parietal cells are more towards the fundus. Parietal cells are more towards the fundus, and chief cells are more towards the body of the stomach. Okay, so this part is referred to as the greater curvature, and this is the lesser curvature. Okay, and this side is referred to as the cardiac side of the stomach. Okay, the fundus and the body. Okay, and then coming down, okay, you have a sphincter over here, sphincter, not like a sphincter, a notch called as the incisural notch that will separate the body to the antrum. Okay, to the antrum. So antrum is the major location where there is secretion of the gastrin. Okay, and from the antrum, the food then from the body, the food moves to the antrum, and from the antrum to the pylorus, and through the pyloric sphincter it passes down to the duodenum. Okay, so this region over here is what is referred to the pylorus and includes the pyloric sphincter. Okay, so the major secretions of the stomach includes the HCl, okay, the intrinsic factor, and the pepsinogen. So these are the secretions that goes into the lumen of the stomach. Okay, whereas there are many other substances that is secreted over here which are endocrine in action. Okay, so there are many endocrine things that is being secreted. Okay, so the vagus nerve is the major regulator here. Okay, that secretes the acetylcholine. Okay, acting through the muscarinic receptor, especially on the parietal cells, and cause the secretion of HCl, cause the secretion of the intrinsic factor that helps the absorption of vitamin B12. Okay, vitamin B12 absorption is essential for the vitamin B12 absorption. Okay, so you can see the parietal cells are more towards the fundus in the body, and little lower in the body you have the chief cells that secretes the pepsinogen. So these are the three things that is being secreted into the lumen. Okay, whereas there are other cells that is secreting to the circulation. Okay, that means as an endocrine hormone. Okay, endocrine hormone. So the one of them is the important G cells. Okay, so the G cells are stimulated by the vagus nerve through the postganglionic neuron and also through the enteric neurons, enteric nervous system, that release gastrin releasing peptide, the GRP, that stimulates the G cells to secrete the gastrin. Then gastrin have direct action on the parietal cell, directly stimulates the parietal cell, and also indirectly stimulates the enterochromaffin like cells, and then release histamine, and then the histamine stimulate the parietal cells. So these are the two actions of the gastrin, major actions of the gastrin on the parietal cells, and cause the increased secretion of the acid. Okay, so there is another cells, that is the mucus cells, that is very important to protect the HCl from damaging the mucosa of the stomach itself. Okay, so the mucous cell secretes the mucus and it forms a mucus lining. Okay, the mucous lining of the stomach is formed by that. And additionally, towards the duodenum we have the D cells. Okay, because it's towards the duodenum, we call that as the D cell. D cell secretes somatostatin. Okay. Somatostatin is the major inhibitory hormone over here. Okay, so this acts as an inhibitory hormone. So inhibition to all other factors like the gastrin and also for the other secretions in the stomach are inhibited by somatostatin. Previously in the endocrine system we have studied that somatostatin is produced in the brain to inhibit the growth hormone, which is produced in the pancreas to inhibit the insulin and the glucagon. So everywhere the somatostatin acts as a inhibitory peptide. Okay, it's a peptide hormone, inhibitory peptide. Okay, then you have the pyloric sphincter over here, and below that is the duodenum. So this is the duodenal part. So in the duodenum you have the I cells, S cells and the K cells. I cell secretes the CCK, the cholecystokinin. S cell secretes the secretin. Okay, under the influence of S cells are stimulated by the acids. The acids stimulate the S cells, and the fat digested or the protein digested and the carbohydrate digested particles stimulate the I cells to secrete the CCK, and the acids stimulate the S cell to secrete the secretin. And especially the glucose, the carbohydrates in the food will stimulate the K cells to secrete the GIP. Okay, so this GIP have two roles. One is the gastric inhibitor, it inhibits the gastrin production, and also it's called as the gas. It inhibits the gastrin, inhibits the G cell. Okay, inhibits the G cell, and also it stimulates. Okay, it stimulates the pancreas to secrete insulin. Okay, so it's sometimes otherwise referred to as the gastric insulinotropic peptide. Okay, so it stimulates the insulin secretion from the pancreas, but it inhibits, the other name is gastric inhibitory peptide, so it inhibits the gastric secretions, the gastrin, especially the gastrin. So these are the major secretions from different parts of the stomach, both endocrine as well as the enzymatic secretion or the exocrine secretion into the lumen of the stomach. Okay, so where are these, like the cells, like the parietal cells or the chief cells, etc. located? Parietal cells is otherwise referred to as the oxyntic cells. Okay, so we are seeing the tubular glands that is present. Okay, there is the oxyntic glands or the gastric glands includes the oxyntic or the parietal cells. Okay, and it secretes the HCl, pepsinogen. Okay, the oxyntic glands, which contains the chief cells, peptic cells, or otherwise called as the chief cells, also secretes the pepsinogen and then the intrinsic factor and little bit of mucus. Okay, so whereas the pyloric glands are towards the pylorus or towards the anus, mainly the mucus. Okay, pepsinogen little bit, and the gastrin is the hormone that is being secreted. So this is, don't confuse between the cells and when we say it as a tubular gland. Okay, tubular gland is slightly different from that of your cell. Okay, so it's important to remember which cell secretes what. Okay, so now let us discuss a little bit more about this intrinsic factor. Okay, intrinsic factor is very essential to bind with vitamin B12. Okay, intrinsic factor binds with vitamin B12. Okay, cyanocobalamin. Okay, and protects it from the damage that it can be caused by the acids. Okay, and it just protects it, the vitamin B12. There is nothing done to the vitamin B12 by the intrinsic factor. Okay, then both this complex of intrinsic factor and the vitamin B12 goes to the terminal ileum. Okay, in the ileum where it is getting absorbed. Okay, so maybe in your biochemistry you might have studied the role of vitamin B12. The role of vitamin B12 is for the methylation processes. Okay, and especially requires for the DNA synthesis. Okay, DNA replication and DNA synthesis, and DNA includes thiamine, so which is very important, thiamine. Okay, the ATGC. Okay, adenine, thymine, guanine, cytosine. Okay, so especially the synthesis of thiamine is requiring the vitamin B12. So what will happen if there is no vitamin B12? The DNA replication will not take place. When the DNA replication does not take place, what happens? the precursor cells. Okay, the precursor cells will come into the cell, will come into the circulation. So what happens in the RBC synthesis? Okay, in the red blood cell synthesis, the precursor cells called as the blast cells. Okay, the blast cells, instead of RBC, the mature RBC, what will be seen in the blood? You will see the blast cells in the blood. Okay, so that condition will be called as what? Megaloblastic anemia. Okay, the condition will be referred to as megaloblastic anemia. Okay, when the blast cells comes, it will be very large for the blood vessels to handle, and they will rupture of that, and thus causing the anemia. Okay, so that is what it is called as a megaloblastic anemia. So megaloblastic anemia can be of different types. Okay, so either due to deficiency of the vitamin B12 from the diet. Okay, so it can be due to a dietary deficiency, okay, from the diet. So this requires a long time, prolonged duration of deficiency of vitamin B12 is required to cause a deficiency from the, for example, you need to stop taking the vitamin B12 for approximately for about 6 months. Okay, so because there will be storage of the vitamin B12 in the liver. So the major sources of the vitamin B12 is the animal products and organs, etc. Okay, the meat contains vitamin B12, so they are the big sources for the vitamin B12, and only if there is a prolonged deficiency, prolonged duration of not taking the vitamin B12, then you can get a deficiency in the diet, or the person may be a vegan. Okay, if a person is like a pure vegan, then he may not have sufficient vitamin B12. Okay, so there is another cause for the megaloblastic anemia, that is you can get the megaloblastic anemia if even if the folic acid deficiency. Okay, folic acid deficiency, because for the methylation process, for the methylation of the thiamine, the DNA synthesis, you need vitamin B12 and the folic acid together. So either the deficiency of folic acid or the deficiency of vitamin B12, both can lead into megaloblastic anemia. Okay, so how to distinguish now? So folic acid is mainly from the plant source. Okay, this is coming from the plant sources like green leafy vegetables, etc. But whereas the vitamin B12 is animal sources. Okay, so the dietary difference, animal sources. Okay, so you have to remember about the dietary source and the dietary deficiency. But otherwise what happens is that you can get a disease condition called as like pernicious anemia. Okay, pernicious anemia. In pernicious anemia, what happens? It is a autoimmune disorder. The pernicious anemia is an autoimmune disorder in which the parietal cells are damaged. Okay, the parietal cell is damaged by the autoantibodies. Okay, the immunoglobulin that is produced in our own body inhibits the parietal cells or damages the parietal cells. Okay, so what will happen? There is no absorption of vitamin B12 at the ileum because it's not protected by the intrinsic factor, so it cannot be absorbed in the ileum. So there will be deficiency and the person will end up in megaloblastic anemia. Okay, so that is another type of like another reasons for the pernicious anemia, the autoimmune destruction. Okay, so what will be the additional feature you will see with this autoimmune? Okay, you will see a chlorhydria, whereas a dietary deficiency of vitamin B12 will not cause a chlorhydria. A chlorhydria means lack of hydrochloric acid in the stomach, because in the pernicious anemia you are damaging the parietal cell, and parietal cell is responsible for secreting both HCl, and so it secretes HCl also, right? Not only the intrinsic factor, parietal cell secretes HCl and the intrinsic factor, so both of them get deficient. Okay, so you will get a chlorhydria and megaloblastic anemia. Okay, so that is the second reason, the diet and the pernicious anemia. Now in addition to that, if there is a damage to the ileum, either like due to some pathological condition, okay, like damage to the ileum, like inflammation in the ileum or the sprue to the ileum, okay, so any of those conditions, or a surgical removal of the ileum. Okay, so that means like there was a cancer or something, and surgically if the ileum is removed, so what will happen? You cannot absorb vitamin B12. Okay, vitamin B12 cannot be absorbed, so that also leads into megaloblastic anemia. Okay, now so those are the three conditions. Okay, the major three reasons. One is dietary deficiency, another one is the autoimmune condition, that is a pernicious anemia, or the resection of the ileum. Okay, all these three conditions can lead to vitamin B12 deficiency. Okay, but how to clinically or like symptoms wise you can distinguish between folic acid and the vitamin B12 deficiency. So folic acid deficiency will lead into megaloblastic anemia. Okay, and vitamin B12 also will lead into megaloblastic anemia. One of the classical difference symptom wise when you read a vignette is to look for the peripheral neuropathy. Okay, so combined neural degeneration. Okay, the neuronal degeneration. So there will be motor deficits and the sensory deficits especially. Okay, so it will cause the peripheral neuropathy. Okay, so vitamin B12 deficiency will cause peripheral neuropathy. Okay, so there will be symptoms that is associated with that, but that is not seen with folic acid. You don't have that problem with the folic acid. Okay, so there are other parameters that you can use to distinguish, that is like in the biochemistry you will know about certain enzymes and certain products that is required for the vitamin B12 and folic acid. But as far as the physiology is concerned, you must know the parietal cell secretes intrinsic factor, and if a damage happens to the parietal cell, that condition is referred to as pernicious anemia. Okay, so pernicious anemia or a dietary deficiency or like a ileum resection etc. can cause megaloblastic anemia. Okay. So let's move forward. Gastric gland secretes about like 2500 ml of gastric juice in a day. Okay, so that is an approximate amount of gastric juice that is produced in a day. Okay, now let us discuss more little bit details about the parietal cell. Okay, so the parietal cell secrete HCl and the intrinsic factor. Okay, and this is the parietal cell, how it looks like. Okay, so you can see this is the lumen, here is the lumen. Okay, here is the lumen of the stomach. So the acids are being secreted in this direction. So on that direction you will see a canaliculi. Okay, so this is like a protective mechanism to protect the cell itself and also to increase the surface area. Okay, so all the acids are being secreted over here into the canaliculi, and through the canaliculi, and the canaliculi are being protected by the mucus. Okay, so you have the very adjacent to that you will have the mucus neck cells. Okay, the mucus secreting neck cells are there, so which keeps on secreting the mucus, so the stomach itself is protected from that. So the two thing importantly, how the acids are being protected, the stomach is being protected from acid is with the help of canaliculi and with the help of the mucus. Okay, so for example, if there is an organism or something that is eating away the mucus, okay, which one is that? You have the H. pylori, right? Helicobacter pylori, might have heard of this bacteria. Okay, Helicobacter pylori, what they do, they produce, they are like urease positive, so they can produce the ammonia. Okay, so the ammonia NH3, okay, which will combine with the acid. Okay, they will take out the acid and then buffer this acid and get converted into the NH4. Okay, ion. So what happens? You have ammonia that is and it takes away the H plus. So what happens? It buffers its surrounding. Okay, so the acids cannot damage the H. pylori. So that is why it survives over here and starts eating away this mucus. So it starts eating away mucus. When they eat away the mucus, what happens? The acid that is coming from here starts to cause damage to the stomach wall itself or the duodenal wall. The acid will cause damage, and then we call that as the peptic ulcer. The ulceration of the stomach will happen. Okay, so that's the importance of this structure. Okay, let's see how this structure is like made used for the surface area. Okay, in this slide we are going to see the different status of the parietal cell, active versus inactive, in which you can see the surface area changing for the intracellular canaliculi. So this is your intracellular canaliculi that you see over here. Okay, so this is the intracellular canaliculi where in the inactive state. So this is the inactive state. Okay, so this is the inactive or the resting state, and this what is shown over here is the active state. You can see the size of the intracellular canaliculi, the active cells. Okay, the active part of the parietal cell, where you can see it is so big, so the surface area is increased by the canaliculi. So what happens over here is the tubulovesicular structure. You can see the small like vesicles, okay, but they are like elongated vesicle. So these elongated vesicle, the tubulovesicular structures, okay, carries the pump, the H plus K plus ATPase pump. Okay, so the H plus K plus ATPase pump, which is the primary active transport, okay, the ATPase, which is the primary active transport, is located on this tubulovesicular structure. So when the resting cell is stimulated to change into the active state, what happens? These tubulovesicular structures goes and fuse with the canaliculi and forms the structure that, like this, called as what? The microvilli. They are called as the microvilli. So now this microvilli contains the H plus K plus ATPase, okay, which will pump the hydrogen ions to the lumen. Okay, so the hydrogen ions are being pumped to the lumen. So this is the luminal side. Okay, so now let us see how this hydrochloric acid is being produced, okay, the HCl, and how, where is the hydrogen coming from. Okay, so this is the differences between the resting versus the active stage histologically. And also you can notice over here, this contains a lot of mitochondria. Okay, the parietal cells contains a lot of number of mitochondria, because you need to have the ATPase pump working. In order for the pump to pump the hydrogen ion, you need a lot of mitochondria. Okay, so those are the features of the parietal cell, resting versus active. Okay, so in this one we are going to see how what is the mechanism of secretion of HCl. Okay, so we start with the carbon dioxide. Okay, so it comes from the carbon dioxide and the reaction of the carbon dioxide with the water in the parietal cell. So in the parietal cell, the carbon dioxide and water is getting reacted in the presence of an enzyme called as what? Carbonic anhydrase. The carbonic anhydrase cause the reaction of carbon dioxide with water to form H2CO3, the carbonic acid, which is very easily dissociated into H plus and HCO3 minus. Okay, so what happens to the H plus? The H plus, this is the lumen. Okay, this is the lumen of the stomach, and this is the blood side. Okay, here you have the blood. Okay, so this is the blood to which all these things are being pumped in. Okay, so here the hydrogen ion is going, and passively what is also going in? The chloride also follows. Okay, so this is what is forming the hydrochloric acid in your stomach, in the lumen. Okay, so now where do you get the hydrogen ion? This is from this reaction, carbon dioxide reaction. And what happens to the bicarbonate ion? The bicarbonate goes back into the blood in exchange for the chloride ion. The chloride is coming, and this is the chloride that is like also like escaping to here. Okay, so going to the lumen. Okay, so this is exchange for the chloride. Okay, so one of the classical example of an transport over here is called as the band 3 protein or band 4.1 protein, etc. Okay, so this bicarbonate is exchanged, okay, so by the chloride bicarbonate exchanger. Okay, so this is exchanged and the bicarbonate goes to the blood. Okay, so this phenomena, when the bicarbonate goes to the blood, okay, what happens to the blood pH? The blood pH is going to be increased. Okay, so the pH of the blood will go high, the pH of the blood will go high, and what happens to the pH of the stomach? The pH of the stomach will be decreased. Okay, it will be decreased. So here it becomes acidic. Okay, the stomach becomes acidic, but on this side it becomes alkaline. On the blood it becomes alkaline. Okay, it becomes alkaline. So this phenomena of converting the blood into an alkaline pH is called as what? Postprandial. Postprandial. Prandial means after the food. Okay, it normally happens after the food, so it's called as the postprandial alkaline tide. Postprandial alkaline tide. Postprandial alkaline tide. Okay, which will be corrected later on when the blood again passes through the pancreas. The bicarbonate will be secreted to the lumen and the hydrogen goes to the blood, so that blood will be like converted back to its normal pH when the blood passes down from the stomach through, when it passes down to the pancreas and the liver. Okay, but initially when it is passing through the stomach to the parietal cell, what happens? The blood will become alkaline in nature. So this phenomena referred to as postprandial alkaline tide. Okay, another phenomena that you observe for this blood that is flowing through the parietal cell is that this is the arterial side of the blood, and on this side is the venous side. Okay, so venous side. So its blood is flowing from arterial to the venous side. Okay, so normally what happens, the cell will give out the carbon dioxide and the carbon dioxide concentration of the venous blood will be higher. Whereas in this cell, what is happening, the cell is taking in carbon dioxide. So what happens to the venous carbon dioxide? The venous carbon dioxide will be less compared to the arterial carbon dioxide. Okay, so there is a speciality of the parietal cell. The parietal cell is consuming the carbon dioxide, especially when the parietal cell is active. When the parietal cell is active, it takes the carbon dioxide in order to synthesize the hydrogen ion. So this phenomena is called as what? Negative respiratory quotient. Okay, this phenomena is called as the negative respiratory quotient. Negative respiratory quotient. Okay, it becomes negative respiratory quotient because there will be more carbon dioxide in the arterial blood than the venous blood. So the venous blood will have less carbon dioxide because the cell is taking the carbon dioxide, which is not seen in other cells. In the other cells, what happens is the carbon dioxide is given out to the blood from the cell when there is metabolism. Okay, so remember these 2 points: negative respiratory quotient, postprandial alkaline tide, and the importance of carbonic anhydrase. Okay, so this is a primary active transport which the H plus K plus ATPase uses the ATP directly. So it's a primary active transport. But whereas in the case of kidney, when you want to secrete, it also uses the carbonic anhydrase. Okay, the kidney also uses the carbonic anhydrase, and the renal tubular cell, unlike the parietal cell which uses the primary active transport over here, it uses secondary active transport. The kidney, it uses secondary active transport. So important for you to remember the differences between the primary active and the secondary active. So here it is secondary active. There is no ATP used by here. So this is the sodium hydrogen exchanger. Sodium goes in and the hydrogen is gone out. Okay, sodium hydrogen exchanger. And what is the primary active over here? It is the sodium potassium ATPase, which is pumping out the sodium and creating the drive for the sodium to come in, and then sodium exchanges the hydrogen for that. Okay, so this is a secondary active transport, whereas this in the parietal cell, it is the primary active. Okay, so it's important later on when we study the renal chapter, you should not confuse between the primary active and the secondary active secretion of the hydrogen ion. Okay, so over here it is the secondary in the kidney, whereas in the parietal it is the primary active transport, the pump. Okay, so moving on. Okay, so let's see the regulation of the gastric secretion. We have seen how the acid is being produced and how the acid is being secreted. Okay, so now what are the features that helps for regulation of the gastric acid secretion? Okay, so the gastric acid secretion is regulated by 3 phases. Okay, there are 3 phases for the regulation. One is the cephalic phase, second one is the gastric phase, and then the third is the intestinal phase. Okay, so these 2 are stimulatory, the cephalic phase and the gastric phase. Cephalic means refers to the head. Okay, cephalic referring to the head. So when the food is there in the mouth, or when the person is thinking about the food or seeing the food or smelling the food, all this refers to as the cephalic phase. Okay, gastric phase is the phase when the food is in the stomach. Okay, and the third one is the intestinal phase. Okay, this is inhibitory, this inhibits. So when the food passes down from the stomach to the intestine, it acts as an inhibitory phase for the acid secretion. Okay, so cephalic phase, it is controlled by what? The parasympathetic, coming from the vagus nerve or the 10th cranial nerve. Okay, the 10th cranial nerve. Okay, so the parasympathetic, okay, releases what? Acetylcholine. So it acts through the acetylcholine and acts through the muscarinic receptor, the M3 receptor. Okay, so that is the cephalic phase. The gastric secretion is controlled by the parasympathetic acetylcholine. Okay, and also excise the pepsin secretion from the chief cells. Okay, so these are the 2 actions done by the parasympathetic. They act directly on the parietal cells and stimulate it. Okay, so secondly, this secondly, in addition to acetylcholine, okay, this can also acetylcholine directly act on the parietal cells and cause the HCl production. It can also act on the G cells. Okay, G cells which cause the production of gastrin. Okay, but over here it's not, the G cells are like stimulated not directly by the acetylcholine. It is stimulated by what? Gastrin releasing peptide, the GRP. Okay, GRP stimulate the G cells. Okay, so there is another action of the parasympathetic. G cells are stimulated and the gastrin. Then the gastrin increases the acid. Okay, the acid production is increased by the gastrin by stimulating the parietal cells. Okay, now when the food is there in the stomach, okay, the gastric phase. Okay, so what are the things that happens in the gastric phase? When the food is there, you have distension. So distension is the primary reason. Okay, so the distension is the primary reason for the gastrin production. So distension of the stomach. Distension of the stomach will cause the production of gastrin, and the gastrin will produces acids from the parietal cell. Okay, so there are local nervous secretory reflexes, okay, and the vagal reflexes, because the distension will cause the vagal reflexes, and then the gastrin stimulation. The gastrin is produced especially from the antrum. Okay, the antrum of the stomach will produce the gastrin, and this gastrin will cause the acid production. Okay, they are the major acid producing stimulus. The gastrin is the major acid producing stimulus. Okay, so now when we go to the third phase, that is the intestinal phase, in which you get inhibition. Okay, so the nervous system will inhibit the antrum for the inhibition of the gastrin production. Okay, the gastrin will be inhibited, okay, by the nervous mechanism, and also by the hormones. Okay, the major hormones like CCK, secretin, and GIP. Okay, GIP, gastric inhibitory peptide. Okay, so GIP, so CCK, secretin, and GIP, these are the three things that will inhibit the gastrin. Okay, so not only the gastrin, not only the secretions, these are the one that is helping for the regulation of movements in the stomach. Okay, so later on we will study about the movements, and these movements are also being controlled or inhibited by this. Okay, okay. So let's see the details of how they causes, how the gastrin and how the acetylcholine helps for this. Okay. So now there are three things that can act, like one is the gastrin directly can act, okay, or acetylcholine can act directly on the parietal cell, or the gastrin can stimulate the enterochromaffin like cell. That means the gastrin can stimulate the enterochromaffin like cell, and then they produce histamine, and then the histamine can act. Okay, so acetylcholine, histamine, and the gastrin will stimulate the parietal cell. Prostaglandins and the somatostatin. Okay, so let's see the detailed image over here. This is from your first aid book. Okay, so let's start with the acetylcholine. Okay, so you get the vagus. Okay, the vagus releases acetylcholine. The postganglionic the parasympathetic neuron release acetylcholine, and this acts through the M3 receptors, which is related to the GQ. Okay, GQ gets cause the stimulation of the IP3, DAG, and the calcium. Okay, and then the IP3, DAG, and the calcium, these are the calcium causes the lodging of the ATPase. Okay, the H plus K plus ATPase will be lodged over here. Okay, so this is the proton pump. Okay, the proton pumps can be there. So where do we get the hydrogen ions from? We have seen before, carbon dioxide plus water in the presence of carbonic anhydrase will give you HCO3 minus and the H plus, right? And the HCO3 minus is exchanged over here for the chloride ions with the help of the band proteins. Okay, the anion exchanger. Okay, so this is the anion exchanger. Okay, so that is M3 GQ. Another one that acts through GQ is the gastrin itself. Okay, where do we get the gastrin from? We get the gastrin from the G cells. What can stimulate the G cells? The GRP, that is released from the vagus nerve, and other enteric nerves can release gastrin releasing peptide. Okay, so that stimulate the G cells, and the gastrin is released, and it acts through the CCK receptor, CCKB receptor. Okay, CCK is actually the cholecystokinin receptor. Okay, so through which the gastrin is acting, but this is not the major action of the gastrin. This is a minor action of the gastrin, and acts through GQ, and then the calcium, then the ATPase. Okay, the H plus K plus ATPase, the proton pump will be stimulated. Okay, so now what is the major action? What is the major way of action of the gastrin? Okay, the gastrin acts by stimulating the enterochromaffin like cell. Okay, the enterochromaffin like cell that release histamine. Okay, and this histamine that is released from the enterochromaffin cell act on which receptor? The H2 receptor. Also, maybe you might have heard about this histamine in other locations. For example, when there is allergic response going on, the mast cells can release histamine into the blood. Can that histamine come and act through H2 receptor? No. Those histamine on the blood circulation, etc., act in the H1 receptor. Okay, H1 receptor is different from that of the H2 receptor. Okay, and that also, that is like in the blood. So those histamine that is released during allergic response cannot come and stimulate the H2 receptor, because you need the histamine over here to release locally by the enterochromaffin like cell. Okay, not the that comes from the circulation is not going to cause the H2 receptor stimulation. Instead, the one that is locally secreted from the enterochromaffin like cell is the one that is responsible for stimulating the H2 receptor. Okay, so for example, when a person is having an allergic response and there is a lot of histamine being released in the body in any other part, can it cause the H2 receptor and can it cause the increased acid production? No, it does not cause that. Okay, so it requires the histamine coming from the enterochromaffin like cell itself to come and cause the action. Okay, now what is the action? It acts through the GS. GS will stimulate the adenylyl cyclase. The adenylyl cyclase causes the conversion of ATP to cyclic AMP. ATP is converted to cyclic AMP. Okay, and cyclic AMP through the protein kinase A will stimulate the H plus K plus ATPase. Okay, and then cause the lodging of it and then cause the pumping of the hydrogen ion. Okay, so that is one action. So there are two other stimuluses that can cause the inhibition of this adenylyl cyclase and conversion of ATP to cyclic AMP. So what are those inhibition? Inhibition comes through the GI coupled receptors. Okay, so what are the GI coupled receptors? So you have somatostatin receptors and the prostaglandin receptors. Okay, so somatostatin, that is coming from your D cells, okay, near the duodenum. So from the D cells you get the somatostatin. Somatostatin acts through the GI. GI means inhibitory. Okay, and inhibits the adenylyl cyclase. Prostaglandin, which is the prostaglandin that is very important over here? Prostaglandin E2. Okay, the prostaglandin E2. So prostaglandin E2 acts through the prostaglandin receptor, that is GI coupled receptor, and causes the inhibition of adenylyl cyclase. Okay, so with regards to prostaglandin, little bit more details about the where do we get these prostaglandins from? Okay, prostaglandins are synthesized from what? From the arachidonic acid. Okay, from the arachidonic acid. Okay, so arachidonic acid is the fat molecule that is present in the lipid, that is present on the phospholipid bilayer. Okay, on the plasma membrane you have the arachidonic acid. Okay, so from this arachidonic acid there are multiple products that can be formed. Okay, there are multiple products that can be formed, like prostaglandins. Okay, it can produce prostaglandins, it can produce leukotrienes, prostacyclins or thromboxanes, etc. Okay, multiple products can be produced from the arachidonic acid. So the major thing that we are looking over here is our prostaglandin. So in order to produce this prostaglandin, what is the rate limiting enzyme that is causing the conversion of arachidonic acid into prostaglandins? They are the cyclooxygenase enzyme, the COX enzyme. Okay, the cyclooxygenase enzyme. Okay, so this cyclooxygenase enzyme is causing the prostaglandin to be produced. And what is the role of all these? Like, there are many physiological functions for that, which include inflammation and fever. These are some examples that can be caused by the prostaglandins. It can cause inflammatory responses, can cause fever. Okay, so these are the classical examples that examples of the actions, the physiological action caused by the prostaglandins. And also with thromboxane you can cause like platelet aggregation and etc. Okay, so there are many actions that is done by the products of the arachidonic acid. Okay, so in order to prevent in the body, what we do in order to prevent the inflammation, in order to prevent the fever, we block this pathway. How we block this pathway is by blocking this enzyme, the COX enzyme. Okay, so naturally from our body what is produced, we have the cortisol, the hormone cortisol, that is can cause an inhibition of the COX enzyme. Or pharmacologically, either you can use cortisol or like a steroid hormone, or you can use non-steroidal anti-inflammatory drugs. Okay, you can use non-steroidal anti-inflammatory drugs The classical examples include the ibuprofen, aspirin, etc. Okay. So when you take this NSAID and cortisol, what does it do? It blocks the COX. So when it blocks the COX, there is no inflammatory response, no prostaglandin being produced. When there is no prostaglandin, you don't get the it acts as an anti-inflammatory, antipyretic, etc. Okay. So that is the action of these drugs. Okay. But what happens in the stomach is that in the stomach you don't produce prostaglandin. When you don't produce the prostaglandin, you don't get the GI action. Okay. The inhibition by the GI you don't get, and what happens? No inhibition of the cyclic AMP. So what will happen to the H plus K plus ATPase? It will be increased, and there will be more hydrogen ions being secreted into the stomach, and this acid in the stomach will cause the corrosive action and cause damage to the mucosa. Okay, so this is one reason for that. We are going to see the other reasons. Okay, and other like whenever you have the reasons, what are the treatment approach you can do? You can use H2 receptor blocker or the atropine when they inhibits the M3 receptor, or the major one that you can use is that the proton pump inhibitors that blocks the H plus K plus ATPase itself, or you can use antacids. Okay, or there are like analogs for the prostaglandin, which is called as the misoprostol. They act similar to that of the prostaglandin, so they act as a prostaglandin analog. So misoprostol act as the prostaglandin analog and cause what? Increased mucus production, increased bicarbonate production, and decrease the acid production, because it increases the inhibition of the adenylyl cyclase. Okay, so let's see what are the other ways that can cause this peptic ulcer. What are the major ways by which you can cause the peptic ulcer, and what is the treatment approach? Okay, very importantly, this slide is very important for you. Okay, very high yield. Okay, this is very important, the peptic ulcer topic. You get a lot of questions from this topic. Okay, so primarily the peptic ulcer is primarily the basic cause for the peptic ulcer. Is the Helicobacter pylori, the H. pylori. Okay, so because it can produce ammonia, it's a urease positive, and ammonia acts as a buffer. It can survive in the acid environment. Okay, so that is the reason why the H. pylori causes that. Okay, and the reason is an aspirin and other NSAID or cortisol. Okay, an increased steroid hormone. Okay, so what will happen? It will inhibit the production of prostaglandins, which is required for the increased production of mucus and the bicarbonate. So you don't have the mucus and bicarbonate, so what will happen? The acids can cause corrosion, and there is no inhibition of the acids because prostaglandin is important for inhibiting the cyclic AMP, right? Okay, and the third reason is like Zollinger-Ellison syndrome. Okay, that is a gastrinomas. Okay, gastrinomas is a gastrin secreting tumor. Okay, gastrin secreting. So your gastrin level, the gastrin level in the body will go like almost like 5 to 10 times more than the normal. Okay, so that's what happens in gastrinoma. So the gastrinoma increases the gastrin, and the gastrin increases the acid production. So where is the location of this gastrinoma? Normally seen in the pancreas. Okay, this is normally seen in the pancreas. Normally seen in the pancreas. Okay, so what are the treatment approach for all these type of peptic ulcer? Okay, so one of them is like, if it is a mild one, you can use the H2 receptor blocker. Okay, the classical one is the cimetidine. Okay, any other drug that ends in this cimetidine. Okay, so that can cause the H2 receptor blocker. Cimetidine is a classical example. The major one that can block, the directly blocking the H plus K plus ATPase is your proton pump inhibitor. Okay, the proton pump inhibitor. The classical example of the proton pump inhibitor is what? The omeprazole. Okay, the prazole group of drugs, omeprazole. Okay, so that can block your proton pumps. Okay, so that is proton pump inhibitor. Okay, but in the case of H. pylori, in addition to the proton pump inhibitor, you may have to add antibiotics. Okay, you may have to add the antibiotics to kill the bacteria. Okay, and if it is induced by the NSAID, then you can add misoprostol. Okay, misoprostol, which is the analog of the prostaglandin itself. Okay, or like in the case of Zollinger-Ellison syndrome, what I have to do? The gastrinomas, what we can do? We can surgically remove it. Okay, surgically remove the tumor from the pancreas. Okay, so that's the treatment approach for the peptic ulcer and the causes for the peptic ulcer. It's an important topic for your exam. Okay, make sure you thoroughly understand that. Okay, now let's move on to the digestion in the stomach. Okay, so what are the various digestive activities that takes place. Okay, so here one of the important digestive activity that did not start in the mouth, that is the protein digestion, that begins in the stomach. Okay, with the help of pepsinogen getting converted to pepsin. Pepsinogen is getting converted to pepsin with the help of the acid. Okay, the acid, the pH, you need the pH, the acidic pH that can cause the conversion of pepsinogen to pepsin. And now what does the pepsin do? It causes the breakage of the bond, the peptide bond between an aromatic amino acid such as phenylalanine or tyrosine and another amino acid. Okay, so you have a long polypeptide that would consume the protein. Okay, so what does they do? What does the pepsin do? They don't break it like completely into individual amino acid. Instead, they break down the large polypeptide into smaller polypeptides. Okay, so it cannot cause the complete digestion. Okay, so that is the importance of the pepsin. It just begins the digestion. So these protein digested particles will be formed. Okay, the protein digestion will begin over here. Another role of the acid, not only for this. Okay, the another role of the acid, one of the role that we have seen is the conversion of pepsinogen to pepsin. And later on, the pepsin have the autocatalytic activity. Pepsin itself can cause the further conversion of pepsinogen to pepsin. So pepsin also have autocatalytic activity. The pepsin can cause the conversion of pepsinogen further to pepsin, more pepsin. Okay. Another action of the acid is for the denaturation of the proteins. Okay. For example, when a person eat raw proteins like the sushi, like raw protein. Okay, so we need to do what? The denaturation of the protein. Then only the pepsin and the pancreatic protein digesting enzymes like trypsin, chymotrypsin, etc. can act on that. The raw proteins cannot be digested by our protein digesting enzymes. So we need to denature the proteins first, then the protein digesting enzymes can act. Okay, so another example is the gelatinase, another enzyme that is acting on the gelatin that is found in the stomach. And the one is the lipase. Okay, the lipase in the stomach is like very less important, especially if you have pancreas. Normal pancreas, lipase in the stomach is not. But in the case of pancreatic insufficiency, the lipase from the stomach and from the saliva, the lipase can contribute about 30% of the digestion of the fat. Okay, so the main, like in a normal person, the major, like almost 100% of the digestion of the fat is mainly done by the pancreatic lipase. Okay, so this contributes very less, but in the case of pancreatic insufficiency, this lipase becomes importance. Okay, so normal person, it is of less importance. Okay, so another thing that is produced in the stomach is what? The intrinsic factor, which binds with vitamin B12 and the protects. We have seen the role of the vitamin B12, the megaloblastic anemia previously. Okay, and the absorption of vitamin B12 takes place in the ileum. Okay, and the autoimmune destruction of the parietal cell is what is referred to as the pernicious anemia. So pernicious anemia will be also associated with echlorhydria. So that means the hydrochloric acid is also not being produced. So what else will happen? There will not be conversion of pepsinogen to pepsin initially, and then the protein digestion in the stomach may not be sufficient. But that can be adjusted with if the pancreatic protein digesting enzymes are there, that is not a problem. Okay, so it won't happen. So echlorhydria cannot. So two things: the denaturation of the proteins will not take place. The conversion of pepsinogen to pepsin will not take place in the case of echlorhydria. Okay. Okay, so now we have finished with the digestion in stomach. We will continue to the gastric movements. Okay, so we start with the gastric motility in the first part when the food is coming to the stomach. Okay, so the first thing that happens is the receptive relaxation of the stomach. The receptive relaxation of the stomach is happening when you eat the food. When you eat the food and the food is going through the esophagus and through the lower esophageal sphincter, when it's coming down to the stomach, then the stomach is relaxed. Especially which part of the stomach? The fundus of the stomach. The fundus of the stomach relaxed and the food will go into the fundus and it gets stored in the fundus. Okay, and that particular phenomena is what is referred to as the receptive relaxation of the stomach. Okay, so in the receptive relaxation of the stomach, it helps to take up the food and store in the stomach, and it also helps to prevent the regurgitation of the food back into the esophagus. So in case if the food is coming through the esophagus, and when it comes to the stomach, and at the same time, if you imagine the stomach is contracting, what will happen? The food will go back. The food will go back to the esophagus, and when the food is going back, and the gastric juice will also go back to the esophagus. So in order to prevent that, as the food is coming down, what will happen? You get the receptive relaxation, especially in the fundus, and the food gets stored in the fundus region of the stomach. Okay, and this prevents the backflow of the food and the gastric juice back into the esophagus. Okay. Now, once the food has been reached the stomach and the fundus is full and the stomach is full, and then you stop eating the food, what happens? Then the next process that starts is the mixing waves. This is the peristaltic constrictor. Okay, so it is happening mainly in the body part. The food will be pushed down from the fundus towards the body, where you have all the secretions coming up. Okay, like the pepsin and the HCl. Okay, it causes the denaturation of the proteins, and then the pepsin starts to act on that, and then it is mixing it thoroughly. Okay, and then it will try to go towards the antrum, but the incissural notch will cause the contraction and push it back again to the body. So this will keep mixing up until the bolus of the food is now converted into a chyme. So the chyme is what? Chyme is a semi-solid. It's like a more liquidy in nature. Because it is more liquidy in nature, then it will squirt little by little into the antrum. Okay, and then after it has been completely mixed with the gastric juice and converted into a chyme, okay, now what will happen? It is the time for emptying of the stomach. Okay, so for emptying of the stomach, you have the pyloric pump working. Okay, let's see how does this happen, the gastric emptying. So in order for the gastric emptying to happen, there are three parts that work together, which are the antrum, the pylorus, and the upper duodenum. Okay, so these three parts contract one after the other. So first the antrum contract, then the pylorus contract, then the duodenum contract. So the food is pushed sequentially from the antrum to the pylorus to the duodenum. Now imagine what happens during relaxation. Which part has to relax first? The first part that has to relax, even though it is sequentially contracting, is not the antrum. So first part that relaxes is the duodenum. Okay, then the part that relaxes is the pylorus, then the antrum relax. This is because, for example, you imagine the antrum is contracting, the food has moved to the pylorus, and when the pylorus is contracting, if you think that the antrum is relaxing, what will happen? The food will go back to the antrum. Or if when the duodenum is contracting, if the pylorus relaxes, what will happen to the food? The food will go back to the pylorus. So in order to prevent that, which is the first part that has to relax? The duodenum has to relax. After the duodenum relax, the pylorus will relax, then the antrum will relax. Okay, so contraction of the antrum is followed by sequential contraction of the pyloric region and the duodenum. So in the antrum, partial contraction ahead of the advancing gastric content prevents the solid mass from entering the duodenum, and they are mixed and crushed again. So that is going back. Okay, so the more the liquid the gastric contents are squirted, so it has to be completely converted into a chyme, and then they are squirted a bit into time into the small intestine. Okay, so in order to prevent the regurgitation from the duodenum, okay, what happens? So why it is not getting regurgitated? Because the contraction of the pyloric segment tends to persist longer than that of the duodenum. Okay, and also the prevention of the regurgitation may also be due to the stimulating action of the CCK and secretin on the pyloric sphincter. So these hormones keeps it contracted. Okay, so that is the role of the CCK. So what caused the stimulation of the CCK? When the food reached the duodenum, okay, the fat and the other protein digested and the carbohydrate digested particles will stimulate the CCK. And what stimulates the secretin? When the food reaches the duodenum, the acid in the food, in the chyme, because the food is coming from the stomach, it will contains a lot of acid, and that acid stimulates the secretin, and both of them will prevent the backflow of that. Okay, so will help to keep the pyloric sphincter intact. Okay, now what are the other factors that helps to regulate the gastric emptying? Okay, so One of them is the gastric factors. Okay, the food itself. Okay, whenever there is a increased food volume in the stomach, it promotes increased emptying. So if you eat lot, like if the volume of the food is more, what will happen? It will empty faster. Okay, the emptying will be faster. Okay, and the gastrin also increase the activity of the pyloric pump. Okay, so if you have like more food, more distension, more gastrin, easy emptying of the stomach. Okay, but depends on what type of food, not only just the volume, but it also depends on the type of the food. Okay, so what are the type of the food which slows down? One of them is the fat is the slowest. So for example, if you take fat for your breakfast, okay, if the breakfast contains like fatty food, like maybe you take an egg or an omelette, what happens? You feel hunger like slightly late. Okay, instead if you take like only like a glass of like juice or something like purely carbohydrate, what will happen? It will empty very fast and its absorption will be very fast, and you start feeling hungry much earlier. Okay, for the lunch. Okay, so if you take the fat in the breakfast, the lunch time can be like little bit delayed. Okay, another example. Okay, for example, when you might have heard of like cheese and wine party, right? So normally when the people who take alcohol, they consume the alcohol along with fat instead of consuming it along with carbohydrate. What is the logic behind that? When the fat is consumed along with alcohol, the emptying time and the absorption time of the alcohol will be slowed down. So what will happen? It will go slowly to the blood, and the intoxication of the alcohol will happen slowly, and the duration of the alcohol intoxication or the alcohol effect on the blood will be prolonged. So it will go slowly. Okay, instead if the alcohol is taken along with some sodas which contains a lot of carbohydrates, what will happen? Its emptying will be faster, and the intoxication effect of the alcohol will go to the brain and get affected very fast. Okay, so that is another like example where you can remember which food makes it slow. So the fat makes the gastric emptying slow. Okay, then by the proteins, and then by the carbohydrates. So the number one that makes it slow is the fat. Okay, so what are the other duodenal factors? Duodenal factors are inhibitory in nature. Okay, so whenever the food is there too much in the duodenum, we don't want more food coming from the stomach. It will allow the food to go away from the duodenum, and then the new food has to come. So it is controlled by the enterogastric nervous feedback. Okay, and hormone like the CCK. Just now we have described CCK, stimulated by the fatty substances in chyme. Okay, act as an inhibitor of the gastrin, and secretin and GIP. GIP is what? Gastric inhibitory peptide. Okay, there is another name for GIP. What is that? Gastric insulinotropic peptide. Okay, it's otherwise also referred to as the gastric insulinotropic peptide. Okay, this is the reason why when you take the glucose, take the food along with the GI through the mouth. Okay, if you are the food is taken, the glucose is taken through the GI through the mouth, what happens? There will be an increased secretion of insulin compared to the same quantity of glucose if you inject it. If you inject the same quantity of insulin, the glucose into the blood, the amount of insulin secreted will be less compared to the same volume of glucose if you consume it orally. If you take it orally, because it will stimulate the gastric insulinotropic peptide, and the gastric insulinotropic peptide will go and stimulate the pancreas to secrete insulin. Okay, so that is why. Okay, but there is another name for the GIP. What is the other name for the GIP? That is called as the gastric inhibitory peptide, because it is causing the inhibition of the gastrin secretion, inhibition of the gastric motility. Okay, so these are the important points that we need to know about the gastric emptying. Okay, and the gastric movements and how they are regulated. Okay, so now let us go into some of the questions regarding the stomach. Okay, that we have studied, now that we have completed with the stomach. So let's discuss few questions that is very relevant for this part. Okay, so here the first question. Okay, the first one for you. Okay, so a 30-year-old male presents with heartburn. Okay, heartburn over the last couple of weeks. He states that he feels a burning sensation in his chest that is usually worse after eating spicy foods and large meals. Okay, so what is the problem in the spicy meals and large meals? It will cause the reflux. Okay, so this is like describing the GERD. Okay, the gastric esophageal reflux disease, GERD, they are describing it over here. So antacids improve his symptoms, but the relief is short-lived and the burning returns. So he often notices a metallic taste in the back of his throat in the morning. So he is obese and actively trying to lose weight. He denies any history of cough, difficulty swallowing, hematemesis or melena. Okay, he has no medical history and he takes no medication. He admits he often has a beer in the evening after work and never more than a two even in the weekend. So his vitals are normal and has no abdominal tendency. So he is diagnosed with GERD. Okay, GERD, and started on prazole. Okay, you hope you remember the prazole group of drugs. Okay, so prazole groups of drug is the proton pump inhibitor, right? The proton pump inhibitor, your PPI, the proton pump inhibitor, which blocks the H plus K plus ATPase, H plus K plus ATPase. Okay, so this question is not trying to ask you what is this condition. They have already given you the diagnosis, that is the GERD. Now the question is asking the physiology part of that. Okay, after 2 weeks of therapy, what would you expect to the relative levels to be as compared to or before treatment? So they are trying to look for the gastric pH and the serum gastrin. What will happen to it? Okay, so after the treatment, okay, after the 2 weeks of treatment, they are asking. Okay, so now gastric pH. What happens to the pH? pH is up. pH up means what? Increase in pH. Increase in pH means what? Alkaline. Okay, alkaline. Okay, in decrease in pH means what? Acidic. Okay, so decrease in pH is acidic. Okay, in this condition, okay, we are treating the PPI and the gastric pH. Okay, pH will go up. Okay, pH will go up, so that is okay. So this part is good, it is up. Okay, so now let's see. So this is wrong, this is wrong. Okay, this is up is correct, this is down is wrong. Okay, up is correct. Okay, so there are like 3 options which is showing up. Okay, so it has to go up. Okay, now let us go to the serum gastrin level. Okay, so what will happen if there is no acid, there is no feedback to the gastrin? Okay, so what should happen? No change is not the answer. Okay, serum gastrin will go down. Okay, okay, good. So whether the serum gastrin will go down? No, the serum there is no negative feedback, so it is not going down. Okay, serum gastrin going up? Yes, that is okay. Serum gastrin going down? No, no changes. No, up is okay. So here you can see gastric pH going up and serum gastrin going up. So this is your answer. Okay, hope it makes sense for you. Good. Okay, so let's go to the next question now. Okay, okay, so this is your second one. Okay, so make sure, like, when you are watching the video, you pause and, like, read the question and try to answer by yourself before you are before I explain to the answer. Okay, you can try it yourself and then listen to the answer. Okay, so here the next one, 23-year-old woman, again with the heartburn, the same condition, also has heartburn, large spicy meals. Okay, and frequently in the guilty pleasure. Okay, she exercises 5 days, BMI is normal, does not drink, smoke or illicit drugs except during her binges. Okay, 2 to 3 times a month she treats herself with margarita and spicy drinks. Okay, okay, and only daring 2-3, that is like, okay, she has an intrauterine contraceptive device, maybe not so relevant over here for the GERD, but otherwise takes no medication and has no medical history. Anticipating the consequences of her intelligence, she purchased over-the-counter famotidine. Okay, the tidine. Okay, so they are what? The H2 receptor blocker, right? The H2 receptor blocker. So she takes it twice a day for 2 days leading up to the weekend and plans on using it twice a day for the 2 days after her celebration. Okay, so this is your H2 receptor blocker. H2 receptor blocker. Okay, blocker. Okay, so now the morning after the event, now this is the question. Okay, so the morning after the event, which of the following is most immediate effect of the drug? Okay, so they are asking the immediate effect of the drug. Okay, so not like the late effect or something, immediate effect. So they are trying to ask you what is the mechanism of action of this drug. Okay, so how does the H2 receptor act? Okay, so H2 receptor act by GQ? No, it does not act through GQ. It acts through the GS. Okay, it acts through the GS. Okay, yes. So in the morning, which of the following is the most immediate effect of the drug? Okay, so it acts through the GS, but here it is saying increased activity of the GS, but it is not increased, right? It will because decreased activity of the GS. Okay, it is not acting through the GI. Okay, so it's acting through the GS. The H2 receptor is acting through the GS. So it's not GQ or GI is not the correct answer. GS is increased by the histamine, but now you are using a blocker, so it should not be increased. Okay, increased cytoplasmic calcium has nothing to do with the calcium, nothing to do with the GQ or calcium. Okay, now it will cause decreased. So if you act through the GS alpha subunit will cause the activation of the adenylyl cyclase. Adenylyl cyclase cause the conversion of ATP to cyclic AMP. Okay, ATP to cyclic AMP. Okay, so what happens to the cyclic AMP? If the GS is stimulated, that will go high, but when you block the GS, what happens to the cyclic AMP? The cyclic AMP level will go down. So that means decreased concentration of the cytoplasmic cyclic AMP. So this should be your answer choice. Okay, good. Okay, so now let us go into the next question. Okay, so now we go to the third question that we have over here. Okay, so this is your third question. Okay, so here also a 46-year-old female, refractory heartburn and abdominal pain. She had experienced severe acid reflux symptoms for 4 weeks and tried over-the-counter medications unsuccessfully. She was then started on maximum dose of proton pump inhibitor therapy. Her reflux modestly improved but persisted after 6 weeks. Okay, so in the interim she has developed gnawing abdominal pain that worsens with eating food. Her vitals and physicals are normal. Her gastrin level is elevated nearly 10 times. Okay, so just like by looking at this, gastrin level increased like almost 10 times, you can understand that this is a gastrinoma. Okay, so that is like a cancerous condition in which a tumor is like causing an increased secretion of the gastrin. Okay, in the to the upper limit of normal. Okay, so the endoscopy reveals multiple ulceration in the stomach and duodenum. Okay, and the rapid test for H. pylori, the Helicobacter pylori, is negative. That means this is not caused due to H. pylori. So it is purely due to the increased gastrin is the problem. And the abdominal pelvic CT with the intravenous contrast reveals a mass in her pancreas. Okay, so from this you can understand the mass in the pancreas is what? Your gastrinoma. Okay, the gastrinoma, which is normally referred to as the Zollinger-Ellison syndrome. Okay, so and for this condition, okay, for which the resection is planned. So the best treatment approach for the gastrinoma or the Zollinger-Ellison syndrome is resection. Okay, the surgical removal of it. Okay, so it has been planned. So in the meantime, while it is being planned, okay, so inhibition of which of the following is most likely to provide benefit in this patient? Okay, so already we have seen that patient got like a little bit of success by using the proton pump inhibitor. Okay, so that means you want to do the same. Okay, so by inhibiting, the problem is due to the ulceration. Okay, so here can be even if we stop the gastric G cell. Okay, gastric G cells are responsible for producing the gastrin. Okay, but this gastrin that is coming in this patient, that is like 10 times more than the normal, is not coming from the G cell. Instead it is coming from the pancreas. So there is no point of like inhibiting the G cell. So instead what you have to inhibit the parietal cell, okay, which is responsible for causing the production of acids, and that is responsible for causing the ulceration. Okay, the peptic ulcer is caused by that. So it is better to stop the action of the parietal cell instead of the G cell. Okay, so pancreatic A cell, nothing. D cell, no role over here. G cell, yes, it produces gastrin, but inhibiting that does not help, because already there is like more than 10 times gastrin already in the patient. Duodenal S cells, duodenal D cells, no. Okay, so it's mainly the gastric parietal cell that can benefit the patient. If we inhibit the gastric parietal cell, that will benefit the patient. Okay, now let's go to the next one. Okay, so this is your fourth one for this topic now. Okay, the fourth question, again the 42-year-old female evaluated for anemia. Okay, so she received annual lab work after not assessing healthcare for over 2 years. She has been tripping over seemingly nothing and experiencing progressive fatigue. Okay, that is one of the important symptoms of your anemia. Okay, she has no medical history and takes no medication. Her vital signs are normal. A physical exam identifies mild deficiency in 2-point touch discrimination, okay, sensory deficit, and proprioception of the lower extremities, that is the motor deficit. So it's a combined sensory and motor deficit, peripheral neuropathy, okay, with anemia, and the hemoglobin level is low. Okay, and very importantly, it is mentioned over here, mean corpuscular volume, the size of the RBC is elevated. Okay, normally it should be like below 100. Okay, 80 to 100 is the normal femtoliters, but what happens over here, it has been elevated. That means the RBC size is becoming big, so it is a macrocytic. So macrocytic anemia, okay, that is what the megaloblastic anemia, that is associated with 2-point discrimination and proprioception of the lower extremities deficiency. Means what, it is due to vitamin B12 and not due to folic acid or something else. Okay, and additional information given, a peripheral blood smear shows what, hypersegmented neutrophils. Hypersegmented neutrophils, again a feature of what, vitamin B12 deficiency. Okay, and folate level is normal, so that it directly, the question is directly telling you it is not due to the folate problem, and her B12 level is nearly undetectable. So the question clearly tells you it is a B12 deficiency. Okay, so these are all the features of the B12 deficiency, and she is positive for anti-parietal cell antibodies. Okay, so when the patient is showing this anti-parietal cell antibody, that means the autoimmune destruction of the parietal cell is happening. So what is that condition? That condition is the pernicious anemia. Pernicious anemia. Okay, pernicious anemia. Okay, endoscopy confirms atrophy of the fundus and echlorhydria. Okay, echlorhydria. So these are the major two things that is produced from the parietal cell. What are they? One is the hydrochloric acid. So what happens to the hydrochloric acid? HCl is reduced over here. And what happens to the intrinsic factor? You don't have the intrinsic factor. That is why the B12 is not being able to absorb. Okay. So now, so the case has been described very well for you. Okay. So now the question, which of the following is the most likely to be elevated in this patient? Okay. So the major problem over here, the question is asking elevated. So echlorhydria means no acid, so no feedback for what, the gastrin. Gastrin is the one that stimulates the acid production. So because of the echlorhydria, what happens, there is no feedback for the gastrin, and the gastrin level will go high. Okay, so even though there are like many other substances, all of them are like stomach related or the GI related, like secretin, no, not affected in this case, because parietal cells are damaged, has nothing to do with the secretin. Okay, so secretin will be actually decreased, because no acid. What stimulates the secretin? The acid stimulates. So this patient is not having the acids, right? Okay, somatostatin, nothing to do with that. Like somatostatin is a general inhibitory, so it is already getting inhibited over here, but there is no need to for somatostatin to be elevated. Okay, GIP, no. Okay, GIP has some other role. Okay, gastric inhibitory peptide helps for what? Gastric inhibitory peptide helps for inhibiting the gastric motility and the gastric secretion and inhibit the gastrin. In addition to that, the gastric inhibitory peptide, otherwise called as the gastric insulinotropic peptide can stimulate the pancreas. Okay, stimulate the pancreas. Okay, but in this case, this is not the option. Okay, and CCK, no, has nothing to do with that. Okay, so it is the echlorhydria that is causing the gastrin to be increased. Okay, so that is elevated in this patient. Okay, hope these questions are like, you are getting used with this type of question, and try to follow as many questions as possible. Okay, not only these. Okay, so try to go for like more questions and like check for that. Okay, so let's do our last question, the fifth one for this topic. Okay. Okay, so a 44-year-old female presented with multiple gastric and duodenal ulcer. Okay, she has been treated empirically with maximum dose of PPI for 6 weeks, but her dyspepsia persisted. Endoscopy revealed multiple large ulcers in the antrum and duodenum. Her gastrin level was again elevated. Okay, very high, almost like 5 times high. So all this telling you what, even though the PPI is given, not getting treated, and the gastrin levels are very high, tells you about Zollinger-Ellison gastrinoma in the pancreas. Okay, and secretin stimulation test, one of the classical tests done for the gastrinoma, resulted in an increase in her gastrin level. Okay, so normally it should decrease, but here because it is a gastrinoma, there is no decrease shown when it is stimulated by the secretin. Okay, so CT also reveals what, a pancreatic mass. Okay, important to see over here, the pancreatic mass. So gastrinomas, normally the Zollinger-Ellison syndrome, seen where the gastrinoma is in the pancreas. Okay, and now after its resection, her gastric level falls to the normal value. Normal is the 100, but it was 500 below. Okay, 500 before, and now it has fallen down after the surgery. Okay, so now the question, so now from where is the hormone normally secreted? Okay, so which hormone they are talking? Where is this hormone means what? That is the gastrin. Okay, so they are talking about the gastrin that is being like increased over here. Okay, so they are asking where is the gastrin normally secreted from. Okay, so the question is asking where is the gastrin normally secreted. Okay, in a normal person. So where is that? In this part, it is from the gastric antrum. Okay, not from the fundus, not from the duodenum, not from the lower esophagus, not in the cardiac part of the stomach. No. Okay, so they are secreted from the gastric antrum. So this is very simple, like they are trying to give you a vignette and then asking you a physiological based question. Okay, so hope you have enjoyed the stomach. Okay, so that's for the stomach. Okay, so in the next video we will see about the small intestine. Okay, we will start with the small intestine, the pancreas, liver, etc. Okay, so thank you for now. Okay, bye.